Next slide. Okay. So after we have already classified whether it is mild, moderate, ataupun severe, we will proceed with this diagram, like indicated in this diagram. Okay.
Okay. All right.
All right. So for this patient, is they moderate ataupun severe kan. So we will start with the nebulized salbutamol plus minus epidropin bromide, oral prednisolone, and give oxygen 8 liter per minute. And then after that, once we have given this, we will observe for 60 minutes and review again. So after we have already treat the acute part, so how will we control the asthma? So we will control the asthma by using the GINA punya classification. Next. So this is the GINA classification, where we will evaluate based on the daytime symptom, nighttime, the need for reliever, any limitation of activity, his lung function test, and also the exacerbation of asthma, the duration of exacerbation. Okay, that's all.
Okay. All right.
Oh, this one. This one is the after we already know the level of the control based on the GINA, we will proceed with the step up and step down punya ladder approach ni.
Yeah. What do you think that this patient still has frequent exacerbation? What do you think the contributing
Trigger. The mother had stated that it could be due to the dust. This one based on the history. Based on the precipitated by the upper respiratory tract infection, smoke, and also dust.
Yeah, but I mean, you took the history, and you said that actually the housing area is actually far from industrial area. The child has no pet, right?
Yes.
So then by then actually, yeah, and then father smoking, yes, correct. But father is actually not smoking inside the house. So basically, you kind of have ruled out the environmental trigger, right? So with this, what do you think another way that you think that this patient can be managed better? Because otherwise he's been having same problem since 2019. What do you think you would do differently probably after taking the history and you have this? What do you think would you probably suggest different thing to the MO or specialist?
I'm not sure, Doctor.
Doctor, maybe we should ask about the compliance to the asthma therapy.
If you, because she said your friend said actually patient is compliant, and it's already stated in the history, right? Of course, we can always argue patient may not be truthful, but I mean if you are satisfied enough, in this patient say they comply, and the environmental factor again, your history is actually not really the trigger. What else do you think can be done to help this patient? Apart from otherwise you guys will be in clinic houseman dan nanti depan ni continue same. Oh, you punya ni. What will you do differently? What will you suggest to the MO specialist?
How about we assess the technique of the using inhaler?
Alright, I hope that after 9 admission, specialist or MO have already observed lah this one. Otherwise daripada houseman sampai ke MO semua pun kena ketuk kepala ni, right? So if the technique is okay, because expecting since 2019 8 admission, I'm sure everyone already thought this patient. What else?
suggest for vaccines like influenza vaccines,
Okay,
additional.
alright. You can try to all these prophylaxis. Hopefully, you can reduce the infection. But again, there's so many type of viruses. RSV, no vaccine. Rhinovirus, no vaccine. But it's not wrong. Okay, suggest that. But you remember that this patient is actually orang asli, yeah. So you probably have to refer this child to what you call this welfare. You feel that actually warranted. I feel it is warranted. In this case, if you're houseman, if you have this idea, please suggest this to MO and specialist. This patient benefit from additional vaccination, orang asli, then you can actually refer to welfare. This idea can come from you, you know. Okay. Should as houseman, active houseman, jangan takut. Sometimes suggest. Sometimes you suggest, you cakap, Dr. Salehin, refer lah patient ni kat welfare. Adalah macam tu. And you better can how about referring this child? Okay, anything else? Any other suggestion? How we can help?
Step up the medication.
Yeah, step up the medication. What do you suggest? This patient has been on budesonide, right? Since 2019.
Yes.
Is it one puff BD atau puff BD?
One.
History. Rasa tadi you kata one puff BD.
Two puff.
Okay, already maximum, already 500 microgram per day. Okay, so step up. What do you mean by step up? Apa yang nak buat? Apa?
Sekejap.
Consider lah laba. What is laba? Apa tu? What is laba? Tulis tak tahu tak?
Formoterol. Formoterol.
No, what is laba?
Long acting.
Follow acting beta agonist.
Long acting beta agonist. Right. Combination. There's no we don't use only long acting. Usually it's a combination of corticosteroid and long acting. Okay, example is fluticasone plus formoterol atau nama dia seretide. Okay, so we can start introducing this. Otherwise, the patient keep coming. Right. So we can start what do you call this? Introducing the ICS and LABA. Okay. Do you think the leukotriene modifier will be helpful in this patient? Probably no, because you said the child has no eczema. Okay, if the child has atopic condition, eczema, rhinitis, then leukotriene inhibitor, okay, would be useful. But if no, the usefulness is actually limited lah. Okay. So step up medication. If you have what you call this, assess the compliant and you feel that the technique is good, always think. Otherwise, you'll be seeing this patient again 3-4 months down the line and then keep blaming non-compliant. Pandai cakap orang non-compliant. And okay. Alright. So okay. Any other slide? You have other slide?
No.
Okay, and so this one kalau you dapat asma ni unlucky lah. For your long case, dapat Datuk Fadil pula tu final exam, hampir lah you. Right, what is expected from you for asma is actually you must know classification of asma lah. Unfortunately, mild, moderate, severe. Persistent, intermittent tu kena tahu tu. Okay?
Okay.
At least from history. From history kena tahu. Alright. Then number 2, asthma, you need to know. Okay, lung function test. For pediatric, we rarely do lah lung function test. Kenapa? They need to be cooperative. They need to know how to inhale and exhale the lung function test. Even for what you call this spirometry, kan dalam dia punya table tu kata spirometry. Kan? You think a 3-year-old boleh blow ke spirometry tu?
Susah.
Susah.
Very difficult, quite
Yeah.
difficult. So lung function test is useful. Is older children. Older children what? I would say that 11-12 tahun lah. 7-8 tahun pun tak ada. So we rarely do lah. Okay, so it's actually a clinical history and assessment lah. Okay, lung function test. You can mention, but again, we have to remember that we rarely do it for small children. They can't perform it. Apa lagi kalau exam? Okay. Management acute exacerbation. Now one is actually measure oxygen supplement lah. And if the pulse oximetry is low, don't forget oxygen supplement. Either nesoprong or high flow mask. Okay. Then you follow the step. And then important is a corticosteroid, either IV or oral. Any different in terms of efficacy? IV versus oral. Do you know?
IV lagi efficient kot? IV lagi efficient?
No different. Evidence-based say that there's no difference between oral or IV. But the problem is, pernah makan Pred tak? Pernah makan oral prednisolone?
Tak pernah.
Try lah.
Pernah, pahit.
It's very bitter, macam makan pengira tau.
Tak ada indication.
Tak ada indication, telah sebiji je, bukan suruh makan 50 mg. Orang ni pun tak rasa ubat, lepas tu pandai-pandai bagi orang makan 8 biji prednisolone untuk nephrotic syndrome. Cuba rasa sekali, sedap tak 8 biji tu? You have to taste all this medicine lah. And tahu sedap tak sedap, main order je. Kan? 8 biji kena makan, satu hari sekali 6 bulan. Kau orang makan tak boleh juga. So, it's very bitter. So it's difficult sometimes for small children. So initially, you probably need to give IV lah, especially if they have poor oral intake. So indication for IV if they cannot tolerate oral medication. If they can tolerate older children, preferably just give oral lah. Okay. Prednisolone and then
Dr. Prednisolone ni 1 year pun boleh bagi juga kalau 1 year tu je.
Yes. Tapi rasa unfortunately pelajar rasa dia kalau nephrotic syndrome say 1 year you have to give oral, what? Can't keep the patient in ward for 6 months kan. So you have to prepare it differently lah. You can prepare dalam air sirap ke, special sirap ke, macam tu. What have you noticed different during this COVID period with regards of management of exacerbation of asthma? You notice tak ada different? Duduk hospital dengan cerita. What's different management of exacerbation asthma in ED during this COVID period? You know, ada guideline. You know?
I don't know.
Aku tahu, tak tahu.
Can I try, doctor? Can I try? I think I know. Because the way we give the medication, it can be through chamber or what's the other one?
Spacer device.
Spacer. So
why?
because of this COVID ni, it's safer to give the chamber.
Kenapa?
Because
Nebulizer tu what happen? You notice bila kita bagi bronchodilator through nebulizer, apa kita nampak?
What
Spread of droplets.
Apa tu kita panggil? What is the term? Kena tahu term tu nak cakap exam ni. Next year exam show kena tanya COVID. Aerosolize.
Aerosolize.
Right. So you see all the vapor is actually aerosolized. So it can spread through the room. Right. So that's why at the moment, if patient has mild exacerbation, preferably we will give the bronchodilator through spacer device. Okay. If they can't, then the specific area where you can keep them to give the bronchodilator. Okay. Mesti kena tanya next year ni. What else long case tanya. Okay, how you assess what you call this poor control? What are the features of poorly controlled asthma that you know in children? Ni siapa? Aina, you present.
Yes.
What are the features of poorly controlled asthma in children?
Fully
Kalau
control
examiner
asthma.
tanya. Apa features that you see in a child with poorly control asthma?
Dia ada exacerbation tu gerak dalam 1
Okay,
minggu.
very frequent. Lagi? What else?
Night symptom.
Okay, what is other objective? More objective punya ni?
The need for reliever.
Okay, right, betul. The reliever is quite objective. Lagi, children? Anyone? Poor weight gain lah. Huh? So sometimes that would be the only features why poorly control. They have poor weight gain. Why? They are making extra effort because of the frequent attack. So they not gaining weight enough. Okay. Apa lagi soalan dia? Tapi dapat asma ni, it's not actually easy. Hopefully, tapi jangan takut lah. At least 10 of you will have asma. Asma can come in long case in 2 situations. In long case 1, okay, they brought in a patient from home who are well. Okay, then on medication. Patient on follow up, tapi tak ada problem apa-apa. Okay, so this is one scenario. Adult macam tu juga. Another situation like this patient came in with exacerbation in ward 24 hours. You are unlucky, patient akan naik ward lah. And some of this patient will have sign. So kalau Aina, kalau patient datang, well patient, okay, dia datang exam ni because for the exam je, they have asthma on MDI budesonide. Past 6 months no exacerbation, dia well actually datang. You tanya dia kenapa datang exam, kenapa datang? Saya panggil tu exam. Okay, so
Okay.
say this is a 5-year-old bronchial asthma. Okay, tapi last 6 months tak ada problem apa-apa. So how you present this to the examiner? Your opening statement, 5-year-old boy,
With
asthma. Cuba present dengan saya. This is long case exam. What will be your chief complaint opening statement here?
Tak ada underlying apa-apa doktor?
Asma lah.
Ali, 5 years old, Malay boy, with underlying childhood asthma.
Cuba datang ni kenapa? So came for this today? Mesti share complaint kena ada kan?
Dia presented dengan
mesti ada complaint of child is well, tak ada apa. Dia datang sebab exam. Datuk Fadil panggil dia hari ni exam. So datang ambil exam dengan you all. So apa yang nak kata?
presented for exam.
So you will have many of these patients came mainly for exam. So how you present it? Oh, example saya nak 8-year-old nephrotic syndrome.
Presented for follow up.
Patang kau perlu datang untuk exam. 8-year-old nephrotic syndrome for past 2 years on prednisolone, tapi hari ni tak ada apa-apa, minggu ni tak ada apa, tapi Dr. Seva datang untuk exam. Okay, or another one say patient has thalassemia major, okay, on monthly transfusion, baru transfuse 3 hari lepas, datang hari ni exam, tak ada apa-apa, saya datang, dia okey sihat je. Dia datang kena panggil exam. So,
tak sure.
So what your opening statement? Mana tak sure dah funny you ni. Tak panggil exam ni. So how you present? Try lah. Try the asthma tadi.
5-year-old boy. Tapi dia presented tak ada apa-apa kan. Dia tak datang.
So just dia datang tu exam. Siapa je tak? Examiner. Examiner menghadap you orang ni. Dia tengah tanya apa you punya opening statement. Apa patient which complain. Apa dia cakap? Ada orang nak try? Siapa bagi nama? Sebut one of your friend yang dalam screen tu. Siapa? Suruh try.
Haikal.
Try.
Presenter. I'm not sure doktor.
Mana ni? So macam ni nak present kalau patient datang macam ni, dia datang dia kata tak exam ni. Okay, this is a 8-year-old boy with underlying nephrotic syndrome. Okay. Currently well and asymptomatic lah. Okay, you tak boleh cakap this 8-year-old Malay boy nephrotic syndrome came today for exam. Marah examiner tu. Dia tak boleh cakap macam tu. Okay. Kalau dia well, currently this 2-year-old boy with underlying bronchial asthma. Okay. Currently well and asymptomatic. Then lepas tu you to start. This child is a 5-year-old. Diagnosed. She's asthma since 2-year-old. Started blah 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 macam tu. Sama juga macam thalassemia. This is a 10-year-old boy. Underlying beta thalassemia major on regular transfusion. Currently asymptomatic. Okay, you start now. This is a boy diagnosed with beta thalassemia major since 6 months age. And started early onset progression. Faham? So the opening statement tu tak boleh cakap patient came today for exam. Jangan sekali-kali. Never. Right? You can't say that patient came to today for exam. Examiner dengar tu ketuk pada you. Right? Clear?
Yeah, clear.
Okay. So any question regarding this asthma? So very common. Dua-dua asthma lagilah common. At least 10 of you will have this either exacerbation or already diagnosed and on treatment. So be very clear. Okay.
Doctor, I have a question.
Okay, sure.
Asma ni ada certain age tak yang kita boleh cakap dia asma? Maknanya
tak ada. You can't, dalam buku tu dia kata you can't diagnose asthma when they are less than 2 years old. Tak betul tu. Not accurate. It's difficult to diagnose asthma when they are less than 2 years old.
Less than 2 years.
Bukan it cannot. Alright, why? Because less than 2 years old, there are many conditions mimic asthma. You have a early childhood wheezer. You have a reactive airway disease. Try not to use reactive airway disease as a final year. Jangan sebut di specialist view word dia reactive airway disease.
Multi-trigger.
Multi-trigger wheeze example. Alright, so these are very common in less than 2 years old. But again, how you generally differentiate is again frequency of exacerbation and of course family history plus any other atopic condition. Okay, if there's strong family history of asthma, then you can say that is likely even this 1-year-old. 1-year-old start having problems since 6 months. For the past 6 months, every month admitted wheezing, and then when you give the bronchodilator, resolve. Next month masuk exacerbation, vaginal nebulizer, resolve. Continuously for 6 months. In a strong family history of asthma, has atopy, right? This it fulfills the criteria of asthma. So this one we call infantile asthma, right? So it's not to say you can't diagnose a child with asthma when they are less than 2 years. It's difficult. Many other condition, right? So must exclude other condition before you say it's asthma. But if you feel history quite clear, straightforward, then your differential at your level, you can still see it's a bronchial asthma. Not wrong. Okay. To be very clear, bukan kata tak boleh. Dalam buku protokol kata tu dia bukan kata tak boleh. The concept is difficult to diagnose when they are less than 2 years old. Okay. So less
2 years tu cakap infantile bronchial asthma ke?
Sorry?
Kalau kata
when we say infantile, usually they are 1 year and below. Okay. When we talk infant. Below 1 year we say infant asthma. Kalau dah masuk 1.5 year, 2 years macam tu, you kata bronchial asthma saja. Okay. So at least they need 3 to 4 months of attack baru. You kata kalau sebulan baru sekali kena, walaupun ada strong family history, say their child is 4 months. Maybe because of wheezing, shortness of breath, father asthmatic, mother asthmatic. First episode, do you say the asthma? No, right? Because of first episode. You have to document there's many episodes before you say it's bronchial asthma. First episode could be just acute bronchiolitis and also mimic asthma.
Okay, faham.
Okay, any other question?
If it's not continuous 6 months, say example, every 2 months pun also can diagnose as asthma.
Yes, every 2 months, for 6 months, example, right? So means that they have 3 consecutive attacks within 6 months. This is also considered as a bronchial asthma with the criteria that we said. Again, if less than 2 years, every 2 months for 6 months, it could still be multi-trigger-wise, could still be reactive airway disease. Tapi when they are older, then you say it's a bronchial asthma. Then you have already need to start prophylaxis because 3 attacks within 6 months. Right, you can't just leave it. Once the moment you start starting the patient on inhaled corticosteroid, then you are stating this as a bronchial asthma. Sekali je taklah. Right? Because criteria is what? Reversibility, isn't it? Okay, recognition reversibility by bronchodilator. So you can document and then got the history as well. Then the reversibility, then you can say it's asthma. Okay?
Okay.
So differential dia tu pun kena when exam, during an exam they will ask you lah. I mean, if patient is already on diagnosed already asthma, we don't ask you differential lah. Right? Already underlying asthma. Very rare lah. I mean, for undergraduate, we're not going to ask you about cystic fibrosis ke apa lah, no. Right? So straightforward. Okay.
Doktor, kalau patient is dia with known case of asthma, lepas tu the age is like below than 5.
Okay.
Viral induced pneumatic trigger wheeze tu macam tak valid lah as the diagnosis.
You can have viral, you can have acute exacerbation of bronchial asthma secondary to viral infection.
Oh.
Okay. You already have acute exacerbation because you already labeled it as asthma. The child has acute exacerbation, you have to find out what's the underlying. So if the underlying is actually viral infection, say acute exacerbation of asthma secondary to viral infection, example. Alright. So the moment you already labeled as bronchial asthma, especially if patient already said there is one memang dah diagnosed as asthma from HTA, from MOSAS ke apa, you stick to that. Right. Tapi you get the clear, try to get a clear history. The problem is actually a new case. Macam baru masuk 2 days ago, first episode. You dapat this case for long case, right? You're gonna have to give differential because first attack, of course you can still say this or she could be a symptom of bronchial asthma, but this is the first attack. Okay. What else? Bronchopneumonia can come with wheezing. Okay, so more than 2 years old, you can't say acute bronchiolitis lah. Acute bronchiolitis is actually less than 2 years, right? So more than 2 years, you can say it's actually say example bronchopneumonia. So can come with wheeze. Okay? So bila dah umur 6-7 tahun, kita tak kata acute bronchiolitis lah. Or viral pneumonia, example. Or can be viral induced wheeze. When we talk about viral induced wheeze, it's actually a first 1 or 2 episode saja. Tapi the moment dia dah jadi 3, 4, 5 macam tu, you dah kena bagi diagnosis. You have to give a diagnosis whether this is asthma or non-asthma. Okay, first episode, you can say it's a viral induced wheeze. Or you can say acute wheezing due to viral infection. It's acceptable lah. First and second especially not really clear. And first and second tu very long. Last year you got, then 1 year suddenly hari ni dapat lagi. Of course, you can't say it's asthma, 1 year span. Then it can still be acute wheezing or viral induced wheeze. Okay, so clear with the definition tu, bronchial asthma.
Doktor, macam biasa kalau jumpa diagnosis dia kata pneumonia with bronchospasm tu.
Okay.
Really, macam mana kita letak bronchospasm tu, maksudnya patient tu come with cough and wheezing ke or cough without wheezing?
Shortness of breath. Wheezing and shortness. When we talk about bronchospasm, your airway is actually tight and narrow lah. So the symptom will be shortness of breath with wheezing. And then when we talk shortness of breath, is until they become hypoxemic. So respiratory drop and so and then they require not just once, they require multiple administration of bronchodilator. And they can be in general ward or can be in ICU. But when we talk about bronchospasm, actually it triggers with at the presence of respiratory distress. significant respiratory distress when you talk about bronchospasm. So by definition, actually acute exacerbation of bronchial asthma is a condition that of a bronchospasm, isn't it? Right? Acute exacerbation asthma is actually a condition of a bronchospasm. So when we talk about bronchopneumonia with bronchospasm, because bronchopneumonia usually it can present in children just fever, shortness of breath because of the consolidation. But the problem is that they also mimics, they have shortness of breath and wheezing and rapid breathing. And this is when we talk about bronchospasm. So kalau masa exam, I doubt lah you're gonna say bronchospasm ni clinical lah. When you work, you see the patient and then bronchopneumonia with bronchospasm. Jangan pakai diagnosis tu masa exam ni, you dapat daripada mana? Examiner tanya. So you just stick to whether this is a bronchopneumonia, infection type, bronchiolitis, or bronchial asthma, Bronchospasm ni you use this as clinical work lah. In exam, I don't think you have this patient tengah terkip ni, orang bawa masuk exam untuk you tak ada lah. Okay.
So letak as differential diagnosis pun tak boleh lah.
Acute bronchospasm is actually in front of you. Right. Child who has exacerbation, child who has a recession, child who has a wheezing, shortness of breath, and respiratory drop, then you say it's acute bronchospasm. Because the treatment is you try acute bronchospasm pun, is actually a clinical diagnosis. Still, the cause can be what? It can be cold induced, it can be viral induced, it can be foreign body. Okay. If you face this patient masa exam, which is I doubt lah, because takkan orang nak masukkan bronchospasm masa bronchis, patient terkip ni pingsan kat situ, and you will never have acute bronchospasm. But when you work, you got a patient in front of you, patient, and then wheezing, shortness of breath, respiratory drop, and then you can say this patient is having acute bronchospasm. What the cause of acute bronchospasm? Could be due to infection. Could this be to a cold induced? Could be to foreign body, right? But you will not have this lah for your long case. But you must understand that acute bronchospasm ni is a clinical diagnosis. Mana ada X-ray kata acute bronchospasm? And bronchospasm is a clinical diagnosis when the patient is in front of you with that features. So basically respiratory distress, but on top of that has a features of wheezing because of narrowing of the airway, but wheezing, right? Kalau respiratory distress saja, you listen, tak ada pun wheezing, you're not going to say acute bronchospasm. You only say respiratory distress lah. But this patient is having respiratory distress, on top here you hear audible wheeze. Or you auscultate, you hear wheezing. Then you say it's acute bronchospasm. Right? Respiratory distress per se, clear macam contoh respiratory distress because of DKA. Kan? Respiratory distress is good to drop juga. Do you say it's acute bronchospasm? No, because there's no presence of airway narrowing. Okay. So I will not recommend you to say acute bronchospasm masa long case. Tak pernah. I think we usually give you straightforward, stable case lah. Right. Kalau cakap bronchopneumonia with bronchospasm tu macam dah dapat notes, clinical notes lah.
Okay.
Okay.
Alright.
Okay. So then tak ada apa, we end up with tasbih kifarah soalas. Okay. Assalamualaikum warahmatullahi wabarakatuh. I'll WhatsApp the marks your presentation. Okay.
Alright, thank you, Uta.